Hi, everybody. So this is our review for Chapter 12. Chapter 12, we talked about drugs that we use for treating infections, so antimicrobial chemotherapy drugs. The main concept behind all of these is selective toxicity. So this is a concept where you want maximal toxicity against the pathogen with minimal damage to the host. So that has to have us include, and think about the concept of therapeutic index. And what that means is the ratio of the drug that would be toxic, the amount of drug toxic to the person versus the minimum effective dose. So, or therapeutic dose, same thing. So the amount of drug that it takes to kill the bacteria versus the amount of drug that it would take to cause bad symptoms in people. And the closer that those values are to one another, the ratio becoming 1, that worse that is. We don't want that. So we want to shoot for something that allows a greater distance between those two. So that's the idea with selective toxicity. We don't want to harm the host, but we do want to kill the bacteria. We do also typically want our drugs to be microbicidal. Microbicidal means we are actually killing the bacteria, as opposed to microbistatic, which is just stopping the growth of the bacteria. So ideally we want microbicidal and not static. Antibiotics that antibiotics are drugs that treat bacterial infections. They don't treat anything else. Antibiotics do not treat a fungal infection. Antibiotics do not treat a viral infection. Antibiotics treat a bacterial infection. Okay. Right. So that's important. If your patient comes to you and has a cold, we do not give them an antibiotic because that doesn't treat the cold. Do not do. Okay. If your patient has obvious bacterial sinus infection as a result of the cold, okay, I understand it. But do not just throw an antibiotic at somebody with a cold. That's bad. It's bad practice. It's the reason why we have this issue. So common drugs that you might want to know for this class. This is the bare bones, guys. You might want to know all of them. That's just my, recommendation. But these are the bare bones minimum, okay? For cell wall, the ones that affect the cell wall, we have the penicillins and other drugs that have beta-lactam rings. Okay, those are the biggies. A beta-lactam ring, remember, it's that square-shaped ring. It's associated with a lot of the penicillins. And carbapenem. You can tell I don't talk about these a lot. Carbapenem, which is an antibiotic, it's like a last line of defense. Ribosomes, we have affecting protein synthesis, the aminoglycosides. This includes tetracycline and glycylcycline and the mycins like streptomycin and erythromycin. Next, we have the folic acid. These are the sulfa drugs. These are going to inhibit folic acid synthesis via competitive inhibition. Couldn't remember the word. Competitive inhibition in the enzyme that's associated with, making folic acid. So then we have ones that associate with inhibiting the cell membrane, or actually tearing it apart in a way. It mimics like a detergent, and that would be polymyxins. These are actually pretty toxic to your kidneys, so they're not great for taking orally. Just saying, but they are used in Neosporin. Next, we have the nucleic acids. These are typically nucleotide analogs. This includes the fluoroquinolones. Floxacins for this one. Okay, so if it ends in floxacin, don't do it, Lauren. Hold on, let me pick my pen. If it ends in floxacin, all right, floxacin. So ciprofloxacin, for example, those are going to be our DNA and RNA inhibitors, basically medications that are going to treat that way. All right, so those are the antibiotics. Next, we have the antivirals. We talked about a lot of the HIV ones. And I mean, there you go. We did talk a little bit about some of the drugs that would be involved in treating COVID, which I can never remember the name of it, and all that. But then we talked about Tamiflu and Remicade. Both of those work the same way, which is by blocking neuraminidase function in influenza, which is how influenza is going to get into the cell. And it does other things as well. So blocking that is a very helpful way of treating influenza infection. And then we had acyclovir. I don't think we talked about acyclovir in this chapter. This is a relic from the old textbook. So we did not talk about that, but I would go back if I were you and kind of look over most of these drugs. I know I should have waited till the end to say it, but most of these drugs, I would try to look through and see the ones that sound quite familiar to you. And if they sound quite familiar, then you might want to know them. Or if I talked about them in the last talk, then you might want to know them. Then we have our antifungals. The big ones here are going to be our azoles. Ketoconazole is one of them. Miconazole, which is monostat, and fluconazole. All of these are antifungals. So those are those. And we also had talked about the other ones, which were like amphotericin B and that. So that's a type of medication you can use to treat a fungal infection. It's not one of the azoles though. All right, antiprotozoal treatment. Quinine was used for malaria. Now we use derivatives and not directly quinine. So chloroquine. So if it ends in quin, then it's malaria, okay? And then we have metronidazole, which is pretty widely used for antiprotozoal infection. And then also for anaerobic bacteria, just FYI. So metronidazole is a useful one. And then anti-helminth treatments, we did go over some of those specifically, but that includes praziquantel and ivermectin, very commonly used anti-helminthic drugs. Also within this chapter, we had talked about the usefulness of the Kirby-Bauer assay. Here, we're going to place our lawn of bacteria across agar and then stamp down antibiotic discs in known concentrations, and then look the next day or however long it takes to grow the sample up to see where the zone of inhibition is. And the smaller the zone of inhibition, the less susceptible or the more resistant. So that means the larger zones of inhibition are going to be more susceptible. So keep that in mind, and we can use that to determine potentially what medications you might want to choose for your patient. But that we don't want to just include our ideas over what happens with our Kirby-Bauer assay. Oh, the Kirby-Bauer assay says that, you know, vancomycin is the best treatment. Let's go. You want to consider the other factors involved as well, which would be the toxicity of the drug related to the effectiveness. So that's that therapeutic index that we were talking about. And then the patient's condition, their age, whether they're pregnant or things like that. All that stuff has to be considered as well. And is there one that we might consider a more first-line defense drug as opposed to, you know, whatever you're looking at that time. All of that has to be considered. You also want to consider side effects. So the drug itself can be harmful. It can have effects on the host's body, such as causing ribosome inhibition for our ribosomes and not just for like bacterial ribosomes. And then any allergies that could develop, anything like that is stuff that you would want to avoid when choosing your drug. There's also something that can occur that's called superinfection, and that's whenever you treat somebody with antibiotics, it kills out their normal biome, and now you have overgrowth of the endospore-forming C. diff, or you have overgrowth of yeast, you know, for causing a yeast infection, and that's common in ladies whenever they take like a antibiotic for a urinary tract or something like that. But so yes, that's something that would want to be considered as well. And then drug resistance itself, it can be intrinsic or it can be acquired. Intrinsic means that the bacteria that produces penicillin, for example, that it has to be resistant to the penicillin so that it's producing. It can't be susceptible to it. So that's intrinsic. Drug resistance, and then we have acquired, which is just gotten from other bacteria. That can be a vertical or that could be a horizontal. Vertical just means that it was transmitted from like the parent organism, but if you got it via conjugation, or transformation or transduction, or maybe even transposons that from other organism, that would be horizontal transmission, right? So those would be acquired. We'd also consider the development of a mutation in the cell that is alive already to be an acquired mutation, and if that allowed it to survive and potentially then grow up and pass on that new trait that it just randomly, spontaneously mutated, which is a possibility and does actually happen. And it's not uncommon. Right. So we have problems with drug resistance due to overprescription whenever people don't need antibiotics and they're being prescribed anyways, as well as using the shotgun approach, which is just like, okay, well, here's some antibiotics, you take these 3 and then you'll definitely kick it. You'll kick your disease, so you won't have to be back here. Especially if there's a situation where it's not even a bacterial infection and it's a viral one. That can cause all sorts of problems. And then the issues with treating livestock, where like something like 80% of livestock, I think, are being treated with antibiotics because it supposedly like makes them healthier and bigger and stronger and better product or whatever. But also is creating antibiotic resistance, which can jump from the cattle to humans. So that is chapter 12 in a nutshell. But man, I really do think that if it would benefit you guys to go back and review the different medications under each of these categories. And yeah, and I'll see you guys next time.